Good morning. Today we'll be talking about HIV, the eradication of HIV and AIDS by the year 2030. This is exciting. This is very promising. Thank you, Professor Akanmu, for coming on the program. It's always a pleasure to have you with us.
You're welcome. It's my pleasure.
And also, Mrs. Dadi, thank you for coming to the program.
It's my pleasure. Thank you for having me.
So, Prof, if we can start off with you. We've been talking about HIV and AIDS for a very long time. But just in case there's somebody out there who has not heard it, who does not know what it is, can you tell us what is HIV, what is AIDS, and why are we thinking of eradicating it by the year 2030?
I doubt if there's anybody now living on planet Earth that, and if he or she is at least 10 years old, that would have heard about HIV and AIDS. I've been talking about HIV and AIDS more than 40 years now, because we started this talk as far back as 1981. HIV happens to be a virus that infects God-given immunity, and that it takes away our immunity and allows an individual to succumb to diseases that can kill chicken. This is what HIV does to the human body. The most important immune cells of the body is the target cell for that particular virus. Removes that immune cells from our body, and then we are so exposed to varieties of infection that ordinarily shouldn't be a problem for human beings. So when we say HIV, we're talking about human immunodeficiency virus, a virus that causes profound immunodeficiency state in human beings. And when that virus is allowed to flourish in the human beings, we are at a risk of suffering from varieties of diseases that we call AIDS. AIDS means acquired immunodeficiency syndrome. That word AIDS means that our immunity is taken away, but that immunity is not an inherited problem, it's an acquired problem. And that acquired issue is the virus that has entered into our body and taken away our immunity, and we are now suffering from varieties of diseases, infectious diseases that easily kill human beings, or infectious or diseases such as cancer that are very difficult to treat and takes away human beings. So acquired immunodeficiency syndrome was the disease that was described in 1981. It was later in 1986 that we now know the cause of that acquired immunodeficiency syndrome, that is due to the presence of a virus that we eventually named HIV, human immunodeficiency virus, a virus that infects human beings and induces profound immunodeficiency state. And we say today, we want to eradicate it, and it's easy now to eradicate it, unlike in the past that we didn't know what to do to treat the virus. Today, we now have very effective agents, effective drugs that are able to prevent the virus from multiplying in our body. That is what the antiretroviral drug has been able to do for us. In the past, the drugs that were available were very toxic to human beings, and they rarely are capable of removing the virus completely from the human body. Today, newer knowledge has come, and simple molecules that are more tolerable by a human body have now been developed. So we are able to use this drug in such a way that the virus is no longer detectable in the blood, and we are able to achieve what we call the goals of antiretroviral therapy. When we give individuals today the so-called antiretroviral drugs, there are certain objectives we want to achieve. Number one, we don't want to see the virus in the blood, and we're able to achieve that today. Number two, we want restoration of immunity that the virus has taken away from our body. We are able to achieve that today. Number 3, we want restoration of health, because with loss of our immunity, there's ill health. That ill health is resolved, and the woman, and we now achieve better health. We call it clinical goal. That's number 3 thing that we achieve. And the number 4 thing that we achieve today is that when the virus is no longer detectable in the human body, ability of those people who harbor the virus, their ability to transfer the virus to another person is cut off. So we are able to prevent transmission of the virus to
That's very exciting.
That are not previously infected. These are the 4 goals of antiviral therapy. We call it virologic goal, immunological goal, clinical goal, and epidemiological goal. That epidemiology means that for every person that is taking antiviral therapy and are effectively treated, there are about 5 to 10 new infections have been prevented from occurring in our population. And that
fantastic.
We are going to achieve a cure or eradication by 2030, and that is what we are premising that hope on, in the sense that if we are living with the virus, we are not able to infect another person, by year 2030, we'll achieve 0 new infection. No new person will be infected with it.
That's absolutely amazing.
Those that are living with the virus, they will not die of HIV-related diseases. This is what we are referring to as viral eradication, or disease or HIV eradication by year 2030. And we have signals that this is achievable today.
That's fantastic. You know, when you spoke earlier, I remember back then, when HIV came out in the late 80s, early 90s, it was devastating. It was frightening. I remember people being so scared because it was an immediate death sentence. There was nothing that can be done. Now to know and see how far science has brought us, that people who would get so sick, so emaciated, so ill and die so quickly, now they're living normal lives. That's what you just said. They're going to live a normal life once they're on treatment. And the treatment is no longer toxic. Back in those days, they were taking bucketfuls of drugs. Toxic drugs really have affected them negatively. And now we're saying it's all a thing of the past. So I really, want to take my hat off to the scientists who have been able to achieve, this real turnaround in this illness that was really so frightening. It was so deadly at that time. So it's wonderful to hear. And what is amazing for me as well is the fact that if you don't have any viruses in the blood, you don't have any viruses in the fluid, then there's no virus with which you can share to anybody else. Because there's a big issue as well with stigma with HIV. And that's one of the biggest issues that stops people from coming out, stops people from doing that. But if you know, and that's what we're now hearing, that they're on treatment, there's no risk, absolutely no risk of transmission, then they are just like you and me. Everybody can just be relaxed around them. You can embrace them. You can, all the things that you were ever afraid of, I think are now a thing of the past. And I think it's very important that people need to know about their status. In the past we talked about their status and people weren't going out because they didn't want to know, they were afraid of getting the label HIV. But now there's a lot that's positive that you're talking about. So I think for me, that's very, very exciting, Prof, and really exciting. So you talked about there were some signs that made us think that this is possible by 2030. What are those signs? Can you share that with us?
Thank you very much. The number 1 sign is the fact that we have been able to detect nearly everybody that is living with the virus. More than 95% of people, we estimate the prevalence of the virus in the human population, and then the number of people that have been able to bring to treatment is nearly getting equal to the number of estimate of people that are living with the virus. That's number one indicator.
Fantastic.
Number two is that more than 95% of people who are on treatment are achieving the goals of treatment, that the virus is no longer detectable in their blood. That is fantastic. Then the number three indicator is what we call incidence prevalence ratio, IPVR, of approximately 0.03. What we mean here is that if an individual is HIV infected and starts to take antiretroviral therapy, the lifespan of that individual has been increased by at least 33 years. Well, when we now have indices, the audiometric measure what we call IPVR, we are now finding out in most population that IPVR is actually getting more than 1/33. What it implies is that in the 33 years that has been added to your life, you will have less than 1 chance of infecting 1 people. That's why we say IPVR of 1/33, which is 0.3. And the metric is actually given in most countries where they are now measuring IPVR. We are even getting a ratio of less than 1/33. These are the indicators that
that's fantastic.
We are very hopeful by year 2030 we might be able to announce a final blow to HIV as an epidemic. We are announcing an end to that epidemic, because we'll be able to say that no new infection is occurring and people that are living with the virus are no longer going to die of the virus. Everybody will die, but the cause of death will not be HIV.
Thank you. Thank you very much. Thank you, Mrs. Dadi, for coming on the program. It is a pleasure to have you. Yeah. So can you tell us, your organization is the Society for Family Health, SFH. Can you tell us what SFH is doing, in particular, what they're doing to bring us closer to eradicating HIV and AIDS by the year 2030?
Okay, thank you very much for having me. SFH is a key implementer in Nigeria in the prevention, treatment, and care for HIV. And we play a vital role in addressing HIV and AIDS in the country. As a key implementer of HIV program, SFH works closely with government, with donors, and other stakeholders to provide HIV prevention, treatment, and care. And such services include prevention and treatment services. We provide HIV counseling and testing, also antiretroviral therapy for those who are living with HIV. We also promote prevention for mother-to-child transmission of HIV. And for me, being the pediatric and adolescent focal person, I'm going to be very biased when it comes to prevention from mother to child, and also pediatric and adolescent HIV services. SFH also distribute condoms and provide HIV prevention education to key population, basically female sex workers, men who have sex with men, and injectable, those who inject drugs, and also those in closed settings, like those in correctional centers, transgender. So we also provide community engagement and mobilization by promoting HIV awareness, reducing stigma, increased HIV access to HIV services. We work with community-based organizations, faith-based organizations, and traditional leaders to reach vulnerable populations in the community. I made mention of key populations because they are the key drivers of the epidemics in our communities, and we try as a public health institution to make sure that this is reduced to its barest minimum. We also provide advocacy and policy support and program that supports national HIV response. We work with government agency, donor, and other stakeholders to ensure services are integrated into national health systems. So Right now in the country, we are also talking about integration of services, like what Prof said earlier, that very soon HIV new infection will be reduced to a barest minimum. It's not going to be a public health threat to people, and that means integration of services to other activities, other healthcare programs in the country. Thank you.
Thank you. No, that's a lot that SFH is doing. Very good work, and it's always nice to know that organizations are out there working for people. So, Prof, if we can come back to you, in terms of just talking to people out there. I mean, even though we've said all of this, there are still some people who know that they are at risk. Can you just give us a few of the something to say? Okay, you know what, guy or girl, you're at risk. You need to test. Can you tell us some of those factors that people need to be looking out for to know they're actually at risk?
Well, I'm not sure whether I got the questions right. Can you please come again, Pamela?
What I was saying was that there are some people listening to this program. We want people to test, but there are some people who need to test more than others. Those are people who are at risk. And so people are listening today, and we want them to know they are at risk and they need to go and test. And they need to know the testing now is the big plus. We've talked about going on treatment, getting an extra 33 years of life. We've talked about so many good things that come with knowing your diagnosis and seeking treatment promptly. So who are the people, and what are the risk factors that people should be looking out for and listening for right now?
All right. Thank you very much. I think I got the question clear now. You are at high risk of becoming HIV infected if you are sexually active and practices sex without discrimination. That's number one. Number two is the special population that Aisha talked about, and that is the people we call key population. They are key population in the sense that we have data to show that as we speak, if 100 new diagnoses is made, 20 of that 100 new diagnoses will come from that particular key population. And whereas that key population constitutes less than 1% of the general population. So they are the point, they're actually fueling the spread of the disease. And why it is so easy that the disease is going to spread from that key population, they can keep recirculating the virus from the group, but the virus also escapes from the group to the general population. Now, the key population, their risk is nearly equal to the risk that a teenage girl will become HIV infected if she has sex with an elderly HIV infected person. Unlike if an elderly woman has a sex with an HIV infected elderly woman. We say the vagina of a teenager is monolayer, is liable to tear, and has a lot of cells that can easily catch virus from HIV infected sperm, get deposited in the vagina, unlike the vagina of an adult woman that is multi-layered and who also produce what we call sex hormones during sex and produce a lot of secretions that we know have fratricidal function, which the young girl does not have. Now, the receptive homosexual, the anal lining of the mucosal lining of the anus is typically like the vagina of a teenage girl that is liable to tear. It is monolayered and has a lot of cells that can easily catch the virus. And there's nothing like secretions in the anus that have ricidal effect. So it is very easy for the virus to easily get inside an individual that we call receptive homosexual. The truth of the matter is that many of the so-called members of the key population are bisexual. When they get it from the population, they transfer it to, and this is why attention has to be focused to members of the key population. We need to carry them along, offer them tests, and let them be knowledgeable to the extent that, look, when you have this virus, it is not going to kill you. You only need to show up for treatment. And this is why we must, during this time, actually, we are targeting a lot of people in the key, but it's a group that is most difficult to target. There are laws that does not recognize their existence.
Doesn't allow them to come out.
These are issues. And of course, there are also careful people who don't want you to know them and who think you will discriminate against them because of their sex preferences. We have a lot of issues there. And if you are talking about this today, and you had the opportunity of listening to us, I'm saying this to them. HIV kills no one again, but it's going to kill you. And it's going to give you diseases that is going to give you the worst pain in life if you do not agree to be treated. And today, you can be prevented from acquiring that disease. Just understand that you are exposed and your partner must receive treatment. And if you are going to have sex with an individual that are not even so sure that he or she is HIV infected, you have today opportunity of taking what we call PrEP, pre-exposure prophylaxis. People today who know that they are going into parties, they are at risk of one thing leading to the other and getting themselves exposed. Please, PrEP is available. Also, be preaching PrEP too. And of course, if you are in a discordant relationship, the husband is infected, the wife is negative, or the wife is infected, the husband is negative, that's a discordant relationship. You must also take PrEP, or let your partner take effective antiretroviral therapy, because if he or she takes effective antiretroviral therapy, he will become uninfectious. These are the situations that we know we must emphasize. Living in discordant relationship, being a member of the key population, you are at a very high risk. And of course, female sex workers are also out there. Their customers are coming. They don't want to use condom. They want to do it flesh to flesh. They are at high risk of becoming HIV infected. This is the situation we find ourselves. But we know.
Thank you very much.
The risk of this transmission is getting reduced because we now have large number of people in the population that are on effective antiretroviral therapy.
So I'd just like to thank you so much for this session. It's gone so quickly, it's amazing. But just to encourage anyone out there, please go and get tested. There's going to be a lot of free testing. I mean, with the HIV Day. So find a way. Get tested, whether free or paid for. And if you are positive, seek treatment. Thank you very much.
Thank you for watching. Please like, share, and subscribe for new video updates.